So thank you for joining again. I'm Dr. Candice Thompson. I'm a breast surgical oncologist at Stanford. I mostly have offices at Emeryville and Pleasanton, and then I operate at Palo Alto also. And thank you for taking time out of your Saturday to learn about breast health and breast cancer within the Black community. It's very important information. The seminar series is sponsored through Stanford Cancer Institute. I have a grant that is allowing us to do all of this once a month. And we are also in partnership with Touch, the Black Breast Cancer Alliance. They're a great organization concerned with Black women and breast cancer and clinical trials. And I'll be showing a short video from the founder of Touch later on. This is meant to be very interactive, so if you have any questions, just raise your hand, stop me, and we can go into detail about anything. So just a little bit of history, things that we've already discussed that I think are important for each of these seminars. We know that Black women are 41% more likely to die of breast cancer compared to white women, and we have a higher relative risk of death compared to white women. We also have the highest mortality rate out of any ethnicity when it comes to breast cancer. Whenever we're diagnosed with breast cancer, we're more likely to be diagnosed with de novo metastatic disease, meaning whenever we're first diagnosed with breast cancer, we are diagnosed with cancer that's spread beyond the breast more often than other groups. We also have the lowest 5-year survival at 81%. This one is important for today. We are just as likely as other groups, especially as white women, to have hereditary breast cancer and mutations that can lead to breast cancer. So that's why we're here today. We previously spoke about dense breast tissue, and we know that Black women are more likely to have denser breast tissue, which can lead to things being missed on mammography. And then we know that Black women have a higher chance of recurrence whenever we're diagnosed with breast cancer. And then when it comes to triple-negative breast cancer, we're more likely to have triple-negative breast cancer, which is one of the more aggressive diseases that's a little bit more difficult to treat. Also, we are more likely to get breast cancer under the age of 35. We're twice as likely to get breast cancer under the age of 35 and 3 times as likely to die from breast cancer under the age of 35, which is why it's very important to know your history and to know your family history and your personal risk. So let's talk about cancer genetics. So it's all a continuum. So I'll go over each of these things. The first thing is identifying your risk. So raise of hands, who in here has undergone a risk assessment? 1, 2, okay, about half of us. And the other half, maybe not so much. So let's go over what is a risk assessment. Does anyone know what we look at whenever we're looking to see whether or not we think you're at higher risk for developing breast cancer in general? Family history, that's a good one. Anything else? Age. That, yes, that's a factor in it also. Okay, so we'll go over. So these are the list of different things that we look at. So things that put you at a slightly elevated risk is if you started your period earlier or if you had late menopause. So that's why whenever you see your OB-GYN or if you do see a breast surgeon or an oncologist, that's why they'll ask you all of these questions. Longer time having periods, so earlier time with starting the periods and later menopause, that means that your body is exposed to estrogen for a longer period of time. So that can put you at a slightly elevated risk. Again, this group is the 1.1 to 2 times average risk. Also, if you had your first pregnancy after the age of 30, if you have dense breast tissue, if you've never been pregnant, if you've never breastfed, if you've used hormone replacement therapy or the oral contraceptive pill, that does put you at a slightly elevated risk. If you have obesity after you go through menopause, if you've had a fibroadenoma or some sort of hyperplasia within your breast, or if you've been exposed to alcohol consumption while you're in utero or when your mother was pregnant with you. No, it's any oral contraceptive use. They've found that there is a slightly increased risk. It's not significantly increased. And there are multiple calculators that we use in order to determine your overall risk assessment. So this all goes into calculators that have been verified by research studies in order to determine whether or not you're elevated risk. So that alone wouldn't make you elevated risk. Good question. Other things that can cause you to be at a slightly more elevated risk is if you have a family history, which is why we're here today. So if you have one affected first-degree relative, that would be your mother, your sibling, your offspring, or if you are known to have a genetic mutation, and we'll go over those different genetic mutations, that can also make you have elevated risk. If you have very dense breast tissue, if you had radiation to your chest previously, or if you have high estrogen levels after you've already gone through menopause. And then significantly elevated risk, as you stated, age is a factor. So as you age, your risk increases. Also, if you have multiple first-degree relatives, so 2 or more, if you are known to have BRCA1 or 2 or any other high-risk gene mutations, which I'll talk about all of those different genes because there is more than just BRCA1 and 2. Also, if you've had a history of carcinoma in situ, which we talked about at the last talk, or atypia, then those put you at elevated risk. Oral contraceptives or birth control pills. The shot hasn't necessarily been associated with elevated risk, and IUDs, same thing, because they're more local and less systemic. Starting menopause early doesn't increase your chances because remember, the longer time period that your body is exposed to the estrogen and progesterone from having periods, that's what puts you at risk. So the shorter the period, then it doesn't put you at elevated risk. Good question. Okay, so let's talk about genetics. Can anyone tell me what the definition of genetics or what genetics is in their mind? Any takers? What do you think of when you think of genetics? Study of the genes. And how they can be passed on through the family. Exactly. Study of the genes and how they can be passed on to the family. That's exactly correct. So it's like you took the words off of my slide. Good job. So that's what it is. We're looking at changes. We're looking at the study of the genes or how certain qualities or traits are passed from parents to offspring as a result of changes in DNA. So when we first took a look at everything, in 1926, the British Ministry of Health, they commissioned a study to look at antecedent conditions of breast cancer. And they looked at 500 cases and 500 controls, and they identified the risk factors that I spoke about before. And they also saw that there are some families and reasons that they couldn't explain in which cancer played havoc, and there are a lot of members of the family having cancer within the same organs. As you can imagine, this was done in 1926. The pool of people that they analyzed were mostly Caucasian. Over the years, genetic analysis has changed. Back in the 1970s, that's when they first started thinking about sequencing the whole genome or looking at a person's whole entire DNA, which is a very rigorous process. It wasn't until pretty recently, in the 1990s, when they started the Human Genome Project, which most of you probably heard about. It was very exciting. We wanted to see what's going on in every single area of a person's DNA, and the thought is we can cure cancer if we know all of that. Well, we're still working on all of that, but we have identified several genes that are genetic mutations that are associated with elevated risk of breast cancer. So, why get genetic testing? So whenever you go to get genetic testing, I don't know, how many of you have undergone genetic testing in here? Oh, okay, 2, okay, great. So whenever you go to get that done, what did they do for you for the genetic testing? How did they get the samples? Okay. Yes. Yep. So it's a very simple blood test. Some companies will send a phlebotomist out to your house to get it done, and then they'll send it off to their lab. They'll analyze it, and then they will send your results back within 2 to 3 weeks. So it's a very simple process, very streamlined these days. A lot of patients are like, what does that mean? What's going to happen to my blood? It's sent off to the lab, and they analyze all of the genes, and typically it's a panel, and they look for anywhere from 50 to 84 different genes to assess whether or not there are mutations in those genes that have been linked to getting breast cancer in your family. There are also saliva tests for some of these companies. 23andMe and Ancestry don't really have the breadth of testing that these specific tests do whenever you go to the doctor's office. So those won't tell you like if you have any other genes other than BRCA sometimes. If it runs in your family, I highly recommend going to your doctor to talk about your risks so you can get adequate genetic testing. Now I'm just going to switch over to a video. This is from Ricky Fairley, who is the founder of Touch, and she's talking about her story with genetic testing.
I was 55 when I got diagnosed with triple-negative breast cancer. When I told my mom, she immediately cried, and she actually blamed herself. And she said, the worst fear I've ever had is passing breast cancer down to you. My mom was 50 when she was diagnosed with stage 0 breast cancer. But she didn't really think about cancer in our family until I got sick. And I said, Mommy, do we have anybody that we know with breast cancer? And then that's when it hit her that her aunt had died of breast cancer. And then I said, well, how did your grandmother die? And she said, a female cancer. And I said, well, what does that mean, Mommy? And she said, well, you know, my mother didn't really talk about it. But that's typical of Black families. We just don't talk about health. And that's because a lot of Black moms or single moms are the breadwinners for their families. And so they don't want to talk about disease and tell people they're sick because they'll make them afraid that they can't take care of them. And we have to get over that. We have to know about who had a disease before us in another generation. It could help save lives and keep people from dying. So a year to the date that I was diagnosed, the cancer came back. My doctor said, get your affairs in order, Ricky, you have 2 years to live. And that was 10 years ago. So I'm very blessed. Black women under the age of 35 get breast cancer at twice the rate than white women of the same age. So my life's mission is to eradicate Black breast cancer. And it's really based on my 3.5-year-old granddaughter The way I look at it, she's gonna get boobs in about 10 years, and I don't want her to ever think about breast cancer. So I got 10 years to do this work.
So that was a very powerful message from Ricky Fairley, the founder of Touch, talking about her journey with her family history. So I want all of you to make sure you grab one of these. It's called, or you can grab as many as you want and hand them out to your family members. It's called Unlock Your Her Story. And this is something, this is a handout from Touch also, which is great because it sort of helps you sit down with your family and go through this and say, hey, did anyone in our family have breast cancer under the age of 45? Did anyone have triple negative breast cancer? Were there any males with breast cancer? I see we finally have a male here. Thank you for joining us. But male breast cancer does occur. And we don't talk about that enough either. Does anyone have a history of pancreatic cancer, prostate cancer, colon cancer? These things also have been linked to family histories of breast cancer. So let's move on. Your lifetime risk of developing breast cancer by age 30, on average, is around 8 to 9%, 12.5% by the age of 95. And then this is just showing that your risk increases with the more relatives that you have that are affected with cancer. So if you have one affected first-degree relative, then your risk is 2 times normal risk. If you have 2 first-degree relatives, then your risk is 3 times the average risk. And if you have 3 or more first-degree relatives that are affected, then your risk is 4 times the risk. There are also some other groups that we know have higher risks, such as Ashkenazi Jewish descent, for developing cancers. So now let's talk about access to genetic testing. We all know that when you go to the doctor as an African American person, sometimes it's difficult to get the care that you need and require. Studies have shown that there are multiple things that play into this. There's lower awareness about these things. There are lower referrals, meaning when you go see a doctor, they're less likely to say, hey, let's get genetic testing for you, even if you do qualify. And there's also lower access to genetic testing services. That's why it's important with companies like Myriad and Ambry Genetics that they have services to help you get this testing when it's necessary. Like they have a mobile phlebotomist. So someone will come to your house, draw your blood, send off the package all for you so that you don't have to worry about figuring out how do I get to get the blood drawn and everything. There are also some gaps so this is just showing different reasons in general, overall, for all races, why patients didn't get tested. And a lot of times it's saying they're saying that the doctor didn't recommend it. Sometimes they're saying that the tests are too expensive. I'm here to let you know if a test is ever too expensive for genetic testing, the companies, they do have ways to help pay for getting the testing done for free. So if you're ever told that, if you're in this situation, make sure you say is there a way to get this compensated by the company? Because they do have methods of doing that. Okay. So again, furthermore, there are some other disparities within this genetic testing. So we know historically that a lot of the genes that they originally sequenced were on Caucasian patients, meaning whenever they try to extrapolate this data out to other ethnicities, it's not necessarily translatable. It doesn't always show certain things that may have been a mutation within the Black community or the Hispanic community or the Asian community that was a mutation in the white community. We do still have the same rates of having BRCA, or other mutations, but there are some other mutations that likely have not been identified. And then also we spoke about there are some disparities that exist in testing. So now we'll talk about which genes exactly are we looking at whenever we're testing. I won't bore you with all of the information on all of the different genes. As you can see, there are a lot of them here. There's still a lot that we need to know. This graph is showing that there are high amounts of mutations associated with breast cancer for BRCA1 and 2, and then some other genetic mutations that we're aware of that put you at higher risk include something called PALB2 and TP53. Those are also considered high-risk genetic mutations, where if you have those, then you're at significantly elevated risk. And this just tells you the numbers as far as like your odds ratio. So if you have BRCA1, you're 26 times more likely to develop triple-negative breast cancer, and also significantly more likely to develop ER-positive breast cancer. For BRCA2, you're almost 9 times more likely. And then for PALB2, you're also 9 times more likely. So those are all considered high-risk genes. And then there are some moderate risk genes, and then there's some lower risk genes. But there are a lot of different genetic mutations that can lead to getting breast cancer. This is just a graph showing those again. So BRCA1's at the top, BRCA2, PALB2, CHEK2 is moderate to high risk. And then there are some others like ATM and things like that. So like I said before, we do know a lot about BRCA1 and 2. We do know a lot about these other higher moderate risk genes, but there's still a lot of genetic variations that are unexplained. However, knowing your family history and knowing your overall risk can help us to determine what steps we can do in order to screen you earlier, in order to have you, if you're interested, have you have early surgery in order to prevent you from getting breast cancer in the future.
So can I just ask not a dumb question, but
There are no dumb questions.
me to think, what is it about the Black genetics that causes us to be more susceptible to cancer genes? I mean, I'm struggling with that.
So we're not necessarily more susceptible to cancer genes. We're just as susceptible to cancer genes. I can show you the graphs from previously, but we're more susceptible to get triple negative breast cancer. But we're just as likely to get all of the other types of breast cancer. The problem is that we are more susceptible to dying from it or for it to come back whenever we do have it. So that's the part that we still need to figure out. There are some really involved scientific conversations that we can have about all of that.
But it's all genetic. It's not, I mean, is it the food? Is it the environment? Is it all of that stuff that we talk about?
It has to do with genetics and things called epigenetics, so things that happen outside of your genome that are affecting how your genetics translate things. There are things called the Duffy genes. There are studies showing that our immune system responds differently whenever we have cancer sometimes. It's not all environmental, but that is a component of things. There's higher stress, which can lead to responding to inflammation or cancers differently. There's so many things that go into it. It's not just one thing, but yes, there are some epigenetic and some genetic factors that play into it, which we're still trying to figure out. And that's why it's important for us to know our history. That's why it's important whenever we are affected to get involved in clinical trials so that we actually have our tissue and our DNA involved in that so we can say, hey, this looks different in our population and figure out why. Good question, though.
Isn't it like the BRCA gene is very much a part of women that are Jewish, right?
So if you're Ashkenazi Jewish, you are a higher risk for getting the BRCA gene. That's correct. But it's not just women who are Jewish. We did have a patient speaker today who was Black, but she couldn't make it. But she was a BRCA survivor. She is a BRCA survivor. She has BRCA mutation. So it happens in Black women also. Yep.
No, I just wanted to say my cancer was related to stress. My system got so stressed out that it affected my immune system. So it's like everything just kind of went wild. So
Yep.
I tell people, and people don't realize that stress can play a big part of
Yep. And we'll talk about that. Yes. Yeah, there are studies showing better outcomes whenever you have less stress also. And we know that there are a lot of factors, just being Black, that can cause you to be stressed. So, yes. Okay, moving on. So, when we're talking about testing, again, these slides are all adapted from Dr. Allison Kurian, thankfully. We do know that what's called VUS, or variant of unknown significance, is higher in non-whites. And what does that mean? So like I was saying earlier, we know that whenever you get tested, if you're found to have a mutation, that's called a pathogenic variant. That means it's something that's definitely been linked to cancer. When you have a variant that's of unknown significance, that means it could lead to cancer, it could not, we don't know yet. So that's one of the situations where they may call you back when later on they get more information and they find, yes, it is linked to cancer, no, it's not linked to cancer. But again, we know that that happens more often in non-white patients because of the reason that I talked about earlier, and having less representation and less diversity in those initial trials. So let's talk about follow-up care. So what can we do about all of these risks? So we know that we can have intensive breast cancer surveillance. The NCCN recommends annual MRIs starting at age 25 and annual mammograms starting at age 30 for patients who we know are at significantly elevated risk with these mutations. Also, if you have a significant elevated family risk and a higher risk personally, then we can start screening earlier for you also. So that's why it's important to get a risk assessment by age 25 so that you know your risk and you know whether or not you're higher risk. I talked about this at our first talk, but MRI can detect cancers when they're smaller compared to mammography. They're more sensitive. And also, it's important to know that surveillance is not significantly different from surgery and survival, meaning having surgery like Angelina Jolie did, if you don't have a mutation, to remove all of your breast tissue is not improving your survival. If you have one of those higher risk mutations, it can improve your survival. So she had BRCA1, I believe, so that would improve her survival. But for those who are at elevated risk, but not at significantly elevated risk, such as BRCA1 or 2 or TP53 or probably 2, then I wouldn't say that it would be strongly recommended. It's a conversation that you can have with your doctor regarding whether or not you want to undergo that. It's still an option, but it doesn't improve your survival. They should test them if you're positive. They should test them. That's typically what the genetic.
From that on what?
I mean, it's a decision as far as your daughters go, and your son should be tested too if you have any sons, because they're still at risk of prostate cancer, pancreatic cancer, and breast cancer. But yes, typically the genetic counselor will recommend testing. Once you're positive, they'll recommend testing the other family members. And then it's up to them as far as whether or not they want to get tested. But I'll go over the things that we can do other than just imaging for if you do test positive. So we talked about MRIs. So what can we do as far as mastectomy goes? So this graph is just showing that your risk for getting breast cancer decreases when you do have BPM stands for bilateral prophylactic mastectomy, or having both of your breasts removed before you get cancer. And for patients who didn't get it, their risk was lower. And then this one is actually showing the BRCA1 and 2. So you can see here, and this is showing the y-axis is the probability of dying from breast cancer. And the dotted line are those who had a mastectomy. And you can see that's higher than the solid line, and that's those patients who didn't have a mastectomy. So for BRCA1 and BRCA2, you can see that there is an increase in survival for those patients. Notice that it's about a 6-7% increase in survival here. For BRCA2, notice it's a 2% increase. So that one is a slight increase in survival. The thing that improves survival the most for these patients is having their ovaries removed prophylactically. And typically, we don't recommend that until around 30 to 40. It varies depending on BRCA1 versus BRCA2. We still recommend, if you want to have children, if you do have a BRCA mutation, you try to have them sooner, and then or do some egg banking, freeze your eggs, so that you can remove your ovaries, because remember, they're at risk for ovarian cancer, and that cancer is the one that can affect survival more. Okay, and then just to further answer your question, so these are all of the breast cancer genes, or not all of them, these are some of the breast cancer genes that are associated with getting breast cancer. And highlighted in this box are the ones that we typically recommend to discuss having a prophylactic mastectomy. And that's BRCA1 and 2, TP53, PALB2, PTEN, CDH1, and STK11. So if you have these mutations, that's when we'll talk with you about prophylactically removing breast tissue. I've had patients who don't have these mutations, who have a very strong history, a very strong family history, and they say, everyone in my family has had it, my genetic testing is negative, and we still have that conversation, and it's still on the table. So I would say, even if you don't have these, it's a discussion that you have with your doctor. It's a personal decision, and then you go from there. So there's just 1 or 2 slides about cancer genomics. I didn't want to get into the nitty-gritty for that, because that one's very involved. Just a simpler form of it, but cancer genetics can help to identify changes that are within the tumor, so that we can target your specific changes within your specific tumor with medication. So it ties along with something that we call precision medicine. And it's an evolving field. We're still finding new targets for tumors. So Myriad also has some precise tests. All of the big companies have different tests for your tumors. If you're oncologist, if you have an oncologist and they ever recommend it, I would say it's a good thing to have your tumor sent off. It's something that they do on the actual specimen that was already removed. It's not another surgery that you would have to have. They send the tissue from the tumor that was already removed off to the lab for them to analyze the DNA within the tumor. And then they'll let you know if there are any specific targets that we know about, and then it'll help guide if you can get specific therapy. So typically this is saved for patients who have very advanced disease that's not responding to other treatments, or recurrent disease that's not responding to other treatments, or just recurrent sometimes. And the order of things is, so after you've had surgery, you'll go see your surgical oncologist to follow up, and then you'll see your medical oncologist to discuss which medications you need. And at that point, they may recommend having your tissue sent for genomic testing. And they will take the tissue that the surgeon already removed and send it to the company. And the company will analyze it, and then they will let you know which mutations are within the tumor. And then if there are medications that we have that can target that, then we'll do that. You do the testing whenever you have, sometimes it'll be like triple negatives that's not responding to anything, or it can even be ER positive. It's a tumor that's not responding to the medication that they're giving. Sometimes we'll just send it off so that we know your tumor genomics from the beginning, and we can, if you do recur, then we can send it off again and see if there's a change within the tumor. It's not on the biopsy specimen. I think, so whenever you get a biopsy done, it's typically done by the radiologist, and they do it with a core needle. So you have a whole bunch of small little strips of tissue that are like 1 millimeter by like 6 millimeters in size. And it's not, you need the actual tumor, what we call the tumor block, to send it off. So you want to have a lot more tissue to be able to send off for them to do the analysis on. It can't just be these small little strips that they did in the biopsy. So that's why you use the surgical specimen. So it can determine the type of treatment that you need. As he alluded to, there are different antibodies that we can use. There are, it doesn't tell you the type of chemo that you'll use, but there are like specific types of medications that can target the tumor based off of whatever mutations we see in the genomic testing of the tumor. Within the tumor, there are multiple cells. And on the cancer cells, there can be different proteins, different receptors that are abnormal or mutated. So it'll target any mutation, they will do a test to look to see if there are mutations within the cancer cell. And then if there is a medication that is available to target that mutation, then they will give you that, and it will target that specific mutation within the cancer. So it's directly treating that area within the cancer that's mutated, that's causing the cancer to grow and divide rapidly. It's not targeting the rest of your body. That's why it's called like precision medicine or like individualized medicine. And it's specifically targeting that area in the tumor, in the cancer cell within the tumor, in order to stop the growth. Just some take-home points for you. Risk assessment should start at age 25. Remember that Black women are at risk for developing for having genetic mutations. Genetic testing can help you as well as your offspring. And then cancer genomics help to have a targeted therapy for your treatment. And thank you all. Remember that you deserve the best medical care possible, and you are your own advocate. If you need an advocate, make sure you bring someone with you whenever you go to the doctor's office. I really appreciate you all being here today.
Thank you.
Of course. Thank you.